Today I'm going to talk about excessive daytime sleepiness, and the objectives are just mainly I'm going to talk about regulatory mechanisms of arousal and sleep, and also talking about some common causes and different diagnoses for excessive daytime sleepiness, and just 2 slides about evaluation and management of daytime sleepiness. I have nothing to disclose. So global brain activation during waking is actually achieved by an ascending arousal system, which is located in the brainstem reticular formation. And there are networks of neuronal systems that is in the brainstem hypothalamus that can promote behavioral and also electrographic aspects of arousal. This network includes monoaminergic neurons in the pons, midbrain, and hypothalamus, which produce serotonin, norepinephrine, and histamine. And also we have cholinergic neurons in the brainstem and basal forebrain that produce acetylcholine, dopaminergic neurons in the ventral tegmental area, periaqueductal gray, and we also have the substantia nigra producing dopamine, but it's not actually, it's not working in the sleep-wake circuit. And we have orexin-containing neurons in the lateral hypothalamus. Talking about histamine, the histaminergic cells in the posterior hypothalamus tuberomammillary nucleus play a major role in the maintenance of wakefulness. And these histaminergic cells are directly inhibited by GABAergic neurons. Activity of the histaminergic cells causes wakefulness, and their inactivity causes the sleepiness. They can be suppressed by GABAergic cells, antihistamine medications that cross the blood-brain barrier, and lesions in the posterior hypothalamus. Then norepinephrine cells, they are mostly localized in the locus coeruleus and the pons. And similar to histaminergic cells, the norepinephrine cells are inactive during REM sleep. There is a difference between activity of norepinephrine and histamine cells, and that's that only the norepinephrine cells become inactive during cataplexy. And studies suggest that a normal cessation of the activity of norepinephrine cells during sleep is related to loss of muscle tone, while normal cessation of activity of histamine cells is related to loss of consciousness. Several studies show that activity in histaminergic cell groups is linked to forebrain arousal, whereas norepinephrine and serotonin cells are associated with regulation of muscle tone and motor activity. Serotonin cell groups are mainly located in the raphe nuclei. These serotonin cells, like histamine and norepinephrine cells, are inactive in sleep, and they have a role in maintaining arousal and also regulating muscle tone. So these cells, as we said, they turn off during REM sleep, mainly because they are inhibited by GABAergic neurons. And the fact that under some circumstances like cataplexy, these 3 cell groups do not cease activity together shows that they can be controlled individually by various GABAergic cell populations. And then we have orexin producing cells in the hypothalamus. They affect many different cell groups. They project to the histamine, norepinephrine, and serotonin producing neurons, and also they can cause glutamate release. In the absence of orexin, physiologic and behavioral instability can occur, like cataplexy in waking or disrupted normal muscle suppression during REM causing RBD. And this instability is due to a dual action of orexin on excitatory and inhibitory neurotransmitters of orexin. Then we have dopamine. Dopamine is very interesting. The largest concentration of dopamine neurons, as we said, is in the substantia nigra ventral tegmental area and periaqueductal gray. It works in several waking brain functions, in motor activity, motivation, and reward. And acute and chronic changes of dopamine signaling in the brain can impact sleep and arousal. And as I mentioned earlier, discharge of dopamine neurons in substantia nigra is not sleep-wake dependent, but dopamine neurons in ventral tegmental area, they have been shown to discharge high-frequency bursts of action potential in waking and also in REM sleep. Dopamine neurons in periaqueductal gray, they also have been shown to affect arousal. These neurons project to hypothalamus and basal forebrain, affecting sleep-wake regulation by especially stimulating acetylcholine, and selective lesions of dopamine neurons in periaqueductal gray cause trouble with arousal. And release of dopamine in the frontal cortex is higher during waking than during sleep. Dopamine deficiency in Parkinson's disease seem to be associated with disrupted nocturnal sleep and excessive daytime sleepiness. But the contribution of dopamine deficiency to daytime sleepiness is controversial. Different studies have shown different findings because we also see that, well, it's my next slide. They can, because Parkinson patients have other sleep problems, like they might have trouble with dystonia, nocturia, restless leg, RBD, sleep apnea. All of these can cause daytime sleepiness with disturbing of the nighttime sleep. And then action of dopamine agonists on sleep and arousal are also complex. We know that increased dopamine signaling is associated with brain activation, but we also see that dopamine agonists in patients with Parkinson's disease can cause sleepiness. And then we also see that dopamine receptor antagonists can cause sleepiness as one of their side effects. So it's very complex. This was a study that I found. They used selegiline and they saw that it reduces sleepiness in patients with Parkinson's disease, but this was a retrospective study. They included 45 patients who started to have daytime sleepiness after they were started on dopamine agonists. And they showed that their sleepiness improved by 5 points using the Epworth. The Parkinson's disease sleepiness scale is actually reversed to higher numbers, less sleepy. L-methamphetamine is a metabolite of selegiline, which can be further metabolized to L-amphetamine and other minor metabolites. And they think that this is what helped with daytime sleepiness in these Parkinson's patients. This is not what we see in rosagiline. Then other studies have shown that sodium oxybate was also helpful in treating daytime sleepiness in patients with Parkinson's, but it's not first line because of the CNS and respiratory depressant effect. And this study mentions not useful treatments when they reviewed other studies, but we still use some of these medications in Parkinson's patients like modafinil, caffeine, methylphenidate, istradefylline, or I think Nurians, and memantine. Their study had limitations because, first of all, it was retrospective study. They didn't have any control group, and the patients that were included in the study didn't have any cognitive decline. So I didn't talk about acetylcholine much, but then there is another other molecules that can affect the sleep other than the neurotransmitters. This was an article that was talking about sleep and its association with changes in the expression of many molecules, some of which are directly involved in sleep regulation. And they also talk about the first study done by Ishimori in 1909. Ishimori was a Japanese physiologist who demonstrated that homogenates from sleep-deprived dogs when injected in non-sleep-deprived dogs induced the sleep. There were similar studies that was done later, reported similar results, but it wasn't until 1960s and 70s that they attempted to isolate and characterize the substances that promote the sleep. One of the first sleep promoting substances called factor S was isolated and purified at Harvard Medical School. This substance progressively increased in the CSF during sleep deprivation. And in the 1980s, factor S was chemically characterized as myramyl peptide, which is a component of microbial cell wall. This graph is showing sleep regulatory substances that form complex biochemical pathways that have positive and negative feedback loops. They change gene transcription, and they actually have effect on sleep over different time scales, like milliseconds, minutes, and hours. This is like very, very complex. For a substance to be classified as a sleep regulatory substance, there are several criteria that need to be met, like, but from the substances that they studied, and they meet all the criteria to be considered a sleep regulatory substance. They were interleukin-1 beta, TNF alpha, growth hormone releasing hormone, that they affected non-REM sleep, and then prolactin and nitric oxide, they affected REM sleep. From all of those molecules that was in that graph, interleukin-1 and TNF have been studied the most. These cytokines are released in response to sleep loss, tissue injury, and infection, and they can have both physiological and pathological function, including modulation of memory, mood, inflammation, and sleep. Sleep loss and altered cytokine levels are associated with enhanced sensitivity to pain, fatigue, sleepiness, and rebound sleep, metabolic syndrome like diabetes, impaired cognition, and memory. And they were actually able to see these symptoms by injecting TNF or interleukin into the models. And then we also see diurnal rhythms of cytokine production. In humans, they have seen that plasma levels of interleukin-1 peaks at the time of habitual sleep onset. So there are mechanisms by which we see the interleukin and TNF in the periphery in the brain. So one of them is by cytokine-mediated activation of the vagus nerve. So this is one of the ways that they think it's going to affect the central nervous system. And then also through the circumventricular organs from homogeneous transfer, and also brain itself can synthesize and release interleukin-1 and TNF. And then in conditions like rheumatoid arthritis, cancer, HIV infections, that they are like chronic inflammatory states, sleep apnea, narcolepsy, acute traumatic brain injury, all of these, in addition to everything else that happens in these conditions, they are associated with increased TNF and consequently sleep fragmentation, sleepiness during the day, and fatigue. So excessive daytime sleepiness refers to tendency to fall asleep in inappropriate settings. Patients have impaired function due to difficulty maintaining wakefulness or alertness at appropriate times during the day. So we have to be able to differentiate excessive daytime sleepiness from mental and physical fatigue, which manifests as difficulty initiating activity, reduced capacity, maintaining activity, and difficulty with concentration and memory. So one thing is fatigue may be worse after positional change or exercise, but it can actually briefly help daytime sleepiness. A patient with a sleepiness may fall asleep when sedentary, but patients with fatigue may not be able to initiate a sleep when at rest. So it's important because these terms can be used interchangeably by patients. So it's not always helpful, but this is what we should consider when the patient says they're tired. About epidemiology of daytime sleepiness, it's reported in 10 to 25% of general population with an equal sex ratio or female predominance of up to 2 to 1. And strongest independent risk factor for incidence of daytime sleepiness were insomnia, smoking, anxiety, depression, somatic symptoms, snoring, and obesity. And I'm thinking that maybe they were not very specific about differentiating sleepiness and fatigue. Okay, so this is a table showing different causes for or differential diagnosis for excessive daytime sleepiness. Talk about some of these so that we can keep in our mind when we see a patient with excessive daytime sleepiness. So the first one is insufficient sleep, especially in, it can be seen in patients who do shift work or mothers who care for kids or have other responsibilities, or it can be from an underlying comorbidity like depression, medical illness, pain. It's also seen in patients who are in the hospital, and then certain medications and drugs of abuse. Then we also have other causes of like sleep disorders. I'm not going to talk about this part that much because we are familiar with most common causes of sleepiness during the day, like different types of sleep apnea, hypoventilation syndromes, central disorders of hypersomnia, circadian rhythm disorders, and restless leg syndrome or periodic limb movement disorder. This one I found funny. I think this is an example that Dr. Stroll uses about narcolepsy. I found it funny. Parasomnias are not usually associated with excessive daytime sleepiness, but insomnia can sometimes be associated with daytime sleepiness, but most of the patients with insomnia, they report fatigue, and they're in a hypervigilant state, not able to nap during the day the same way that they're not able to fall asleep at night. And then there are neurological conditions associated with daytime sleepiness, like focal CNS lesions, especially if they affect the sleep-wake circuit. Stroke. Sleepiness and fatigue are common after stroke, and they can be associated with poor outcomes in stroke patients. And they have also been, it's shown that 60% of stroke survivors have obstructive sleep apnea or central, any type of sleep apnea. And sometimes daytime sleepiness can be a direct result of a stroke, especially if the area that's affected by stroke is in the midline structures affecting wake sleep circuits. And also it can be from side effects of medications used. Tumors, again, the same, especially if they're in the hypothalamus or midbrain, or that's a direct way of causing daytime sleepiness, or indirectly by causing hydrocephalus and increasing the ICP. These patients usually can present with morning headaches, but it's not alarming unless the patient has some neurological findings, because patients with sleep apnea and hypoventilation can also present with morning headaches and sleepiness during the day. And traumatic brain injury, 50 to 80% of patients with TBI reported daytime sleepiness, which can be because of acute reduction in orexin level in the CSF, but this can recover. But in traumatic brain injury, there might be hypothalamic neurons injury that can cause reduction of the histamine. MS patients report sleepiness during the day and fatigue, which one of the causes might be the areas, again, working in the wake sleep circuit, or systemic inflammation, as we talked about, interleukin 1, TNF, and other cytokines. And patients with MS are also at increased risk for RLS and sleep apnea. And it can also be because of the side effect of medications used. Neurosarcoidosis. So sarcoidosis usually affects the base of the brain and hypothalamus. That might be the reason that it causes daytime sleepiness. But the patients who present with neurosarcoidosis usually have evidence of systemic disease on their chest X-ray or CT. Epilepsy, as we know, sleep deprivation can worsen epilepsy, and poor epilepsy control can affect the sleep. And patients who are poorly controlled need more anti-seizure medications that can directly cause sleepiness, or they can cause relaxation of the upper airway muscles and worsen the sleep apnea. Then neurodegenerative diseases like Parkinson's, we talked about. It's very, so many different causes for sleepiness in Parkinson's patients. Then multiple system atrophy, dementia with Lewy body, and Alzheimer's disease. So the first three ones can present also with RBD, and Alzheimer patients have usually disruption of the circadian rhythm. Headache patients are found to have more daytime sleepiness comparing to the general population, and one of the reasons might be the medications they take sometimes to prevent further headaches from happening. And medical conditions causing daytime sleepiness. Cardiovascular disease. So patients who have cardiovascular disease are also mostly have other metabolic problems, obesity, and also heart failure is associated with central sleep apnea and chain stop respiration. Respiratory conditions like COPD, it can be associated with oxygen desaturation despite minimal respiratory events on the PSG. And associated hypoxia and hypercapnia may cause cerebral injury and consequently cause daytime sleepiness. Another cause for daytime sleepiness in respiratory conditions is chronic cough, which can cause fragmentation of sleep and also systemic inflammation, leading to daytime sleepiness. Hematologic disorders like iron deficiency is associated with restless leg, LM, and hemochromatosis. Excessive iron can cause daytime sleepiness, and the other indirect way of causing daytime sleepiness is causing hepatic dysfunction and other endocrine dysfunction as a result of iron deposition in the pituitary. And also sickle cell patients, they are more frequently prone to have sleep disordered breathing and sleep apnea. And also it's shown that sleep apnea may increase the frequency of acute pain episodes and chronic cardiopulmonary disease in these patients. Metabolic encephalopathy, like hepatic dysfunction, chronic liver disease, and they also have been shown to be associated with excessive daytime sleepiness. Renal failure patients are also presenting with daytime sleepiness. Patients with ESRD are at increased risk of sleep apnea, which can be worsened by fluid overload. Then also restless leg, periodic limb movement, they can affect up to 50% of patients on hemodialysis. Other possible contributing factors include insomnia, poor sleep quality, and side effects from medications. Endocrine disorders like diabetes, hypothyroidism, pituitary adenoma, Addison's disease, they all can be associated with daytime sleepiness. In patients with diabetes, episodes of severe hypoglycemia may increase the likelihood of daytime sleepiness. And then polycystic ovarian syndrome can present with daytime sleepiness. They also have increased incidence of sleep disordered breathing. Toxin exposure, like organic solvents, can cause daytime sleepiness by damaging the white matter tracts that are involved in the sleep wakefulness circuit. And so an occupational history may help identify exposure to these agents. Peptic ulcer disease and reflux, they can also present, patients can present with daytime sleepiness. In a study of more than 2,500 adults with range of medical disorders and no suspicion for sleep apnea or narcolepsy, peptic ulcer disease was the most common medical disorder associated with the sleepiness, with 50% of patients reported daytime sleepiness. GERD can cause arousal from sleep that we may not be able to realize during the routine PSG because we do not monitor esophageal pH. In patients with daytime reflux and sleepiness that is otherwise unexplained, dietary manipulation, sleeping in the left lateral decubitus position, the head of the bed slightly raised, and a trial of acid-reducing agent, this can help clarify the diagnosis. Vitamin deficiencies, in severe cases, vitamin B12 deficiency can be associated with white matter lesions and subsequent daytime sleepiness. Limited data suggests that vitamin B12 also has effects on circadian rhythms. It can also be caused by exposure to nitric oxide. Vitamin D deficiency occurs with increased frequency in MS and sleep apnea, but whether vitamin D deficiency is causing daytime sleepiness is unclear. The relationship may be confounded by reduced light exposure and physical activity in this patient population. Pregnant women are nearly twice as likely as controls to report daytime sleepiness. Sleep is often disrupted during pregnancy with multiple contributors: hormonal changes, back pain, other physical discomforts, sleep disordered breathing, and RLS. And this sleep disruption may persist postpartum independent of care of the newborn. Then we also have psychiatric disorders and medications that can present with daytime sleepiness. Substance abuse, alcohol, acute and chronic, both can present with daytime sleepiness. Acutely with sedating effect, chronically with fragmenting sleep. Marijuana can also produce daytime sleepiness, can cause changes on the MSLT, which is similar to what we find in narcolepsy patients. Opioids can induce chronic daytime sleepiness, independent of their effect on breathing patterns and apnea during sleep. GHB intoxication should also be considered in cases of profound coma that resolves in several hours with negative toxicology screen, because they have GHB has a very short, not a very, but short half-life. And to confirm the presence of GHB, we need gas chromatography or mass spectrometry analysis. Withdrawal of stimulating substances can also cause daytime sleepiness. Cocaine, amphetamine, caffeine, all of these can present with daytime sleepiness. And there are medications that patients might not be aware of the presence of caffeine in them: Excedrin, migraine, Furosemide, and some other medications. About medications, so the main thing we should pay attention to is the medication list of the patient, because they can either directly cause sleepiness, or they can aggravate some type of a sleep disorder, worsening daytime sleepiness, like restless leg, and also obstructive sleep apnea with the muscle relaxation effect. For initial evaluation of the patient, so we need a thorough history, physical exam, interviewing family members, screen for depression, blood work if you're thinking about iron deficiency, vitamin deficiencies, or other types of other differential diagnosis that we have in mind. Sleep log actigraphy can help with realizing if the patient has insufficient sleep, PSG, MSLT. And as far as the management, so we can do behavioral counseling about insufficient sleep, poor sleep hygiene, circadian rhythm, sleep-wake disorder, treating the sleep apnea or hyperventilation syndrome, medications to treat restless leg, stimulants for central disorders of hypersomnia, and changing the medications that cause daytime sleepiness, moving them during the day, the ones that are alerting, moving them to take in the morning, the ones that are sedating to be taken at night, treat underlying conditions like medical, psychiatric, chronic pain, or depression. And regardless of the underlying cause, patients with daytime sleepiness should be warned about the risk of drowsy driving and also educated about prevention and risk modification. That was my presentation.